This is Seth Lerner. I'm a urologic oncologist at Baylor College of Medicine, and I'm the principal investigator of a novel intervention trial for patients with low-grade upper urinary tract cancer. And as everybody knows, this can be a very challenging disease to manage, even with current state-of-the-art endoscopic techniques. There are plenty of patients with large volume tumors, patients with very difficult to access tumors, particularly in a lower pole calyx, that really outstrip our ability to manage short of a radical nephrectomy. The other aspect of care for these patients is we can deliver traditional chemotherapy and even BCG to the upper urinary tract just like we do for the bladder, but there's lots of limitations in terms of contact time, difficulty getting access, and I think it makes for a difficult clinical management scenario, and oftentimes these patients are simply treated with nephrectomy. And the other part of it is that a lot of patients are not medically fit necessarily or high risk for undergoing a major surgical procedure, and so that sort of presents an ideal situation for perhaps a novel delivery system that, in this case, using a thermo-reversible gel that's been developed by a company called Urology. The name of the drug is UGN-101, and it's essentially a combination of a thermo-reversible gel. What does that mean? The gel is liquid at low temperature, meaning at cold temperature, therefore you can inject it through a ureteral catheter, and semi-solid at body temperature, and so in this case, if you inject it up to the kidney, it'll retain it over about 4 to 6 hours. It's a water-soluble gel, so ultimately it'll pass in the urine. And then this is combined with mitomycin. So mitomycin can be a very effective drug for treating low-grade disease. And so the idea is just to deliver an adequate amount of drug, concentration of drug, and most importantly, have it stay in the kidney an adequate period of time, in this case, several hours. And the gel can actually go all the way into the entire infundibulocalyceal system. Working with the company, we designed a trial to do weekly installations for patients who have biopsy-proven low-grade disease. In order to minimize the risk of high-grade disease, they have a biopsy, they have a negative cytology, and the majority of those patients ultimately will have low-grade disease, but we acknowledge that we'll miss some patients with high-grade disease. So most of the patients in this trial were treated by ureteral catheter. You can deliver the treatment through a nephrostomy tube, and so it was treat weekly for 6 weeks, and then reassess the patient with ureteroscopy about 6 weeks after completion of treatment. Patients who had a complete response could go on to get maintenance treatment as well. We had 74 patients with pathologically confirmed low-grade disease, and the bar was actually set fairly low by the FDA at around 15% initial complete response rate. That was because this is a patient population for whom radical nephrectomy or nephroureterectomy would otherwise be required. So of those 74 patients, 71 completed the first disease evaluation after 6 weeks of treatment. About half of them had multiple tumors at baseline, and about half had tumors that were unreachable via ureteroscopy. And as I mentioned before, the most common location for that would be the lower pole calyx. We were struck by the initial complete response rate of 59%, so 42 out of the 71 patients did achieve a complete response. And then all but one went into follow-up, and about 2/3 of those 41 patients have undergone surveillance at 6 months, and the vast majority of those, about 89%, have remained disease-free at 6 months. So the complete response rate far exceeded what the sort of low end of efficacy set by the FDA, and the majority of those patients have maintained a disease-free state at least through 6 months. They're all being followed out to 12 months. And then of the particular group of patients that were endoscopically unresectable, they also had a 59% complete response rate, and 85% of those remained disease-free at 6 months. The treatment is well tolerated, but one of the things that we've observed are ureteral strictures and associated hydronephrosis. And the thinking there is that that may be due to repeated instrumentation, right? So we're catheterizing the upper urinary tract weekly for 6 weeks. A lot of these patients have had multiple ureteroscopies, and then there's at least a possibility that this could somehow be related to mitomycin. Most of those have been easy to manage with just stenting or balloon dilation and stenting. And so even though it occurs at a frequency higher than we would have perhaps liked or expected, virtually all of those, it's not had necessarily an adverse outcome for the vast majority of those patients in terms of subsequently having to have, say, a nephrectomy for intractable stricture disease. So I think what we found with the trial is that this mitomycin and delivered with thermoreversible gel can be done safely. One of the nice things is that, and my experience as well as others have been, you just do a flexible cysto in the office, pass a wire, put the catheter in, confirm by imaging that it's in the right location, deliver the drug, and patients seem to do quite well with that, with the weekly treatments, given the trade-off being that they may otherwise require a nephrectomy. And then the initial complete response and the durability of that is very encouraging. There's if approved by the FDA, this would provide a nice alternative for the initial management of patients with low-grade disease specifically. So thank you very much. Appreciate it.